Hello, coders. Good morning, good evening, good afternoon, all depending upon where you're joining us from. Welcome back, everyone, to another CPT mastery session with AMCI. How are you all doing? And please do let me know in the chat. How do I sound? Am I audible? Is my good? Please do let me know in the chat before we move on. So it is always amazing to see you all back, energized and ready to level up your coding skills. So get comfortable, coders, grab your CPT manual and keep those highlighters handy. All right, thank you for letting me know, Kathy and Tiffany. Hi, welcome, Newtlin. Welcome everyone. Thank you for letting me know that my sound is good. Okay, so today we are diving into another important topic that shows up everywhere in the exam and in the real world coding as well. So let's get started and make another power packed AMCI session. All right, let's begin by reading out the copyright CPT copyright 2026 American Medical Association, all right reserved. CPC is a registered trademark of AAPC, and the AAPC content found within this presentation is a copyright of AAPC. Keyword concept FTR Chon AMCI Fab 7 AMCI ICD 10 Flip Tap and MCG are the trademark of AMCI. The credentials CPCC, RCC, OC, CPMA, CPB, CPPM, CPCO are owned by AAPC, and AMCI do not own right to these credential. And the credential CCA, CCS, CCS-P, RHIA, RHIT are owned by AHIMA, and AMCI do not own right to these credential. Hello everyone, I can see all your chats. Hi Miss Veena. Hi Kinio Hethel. I hope I'm pronouncing it right. Hi Star Wars Girl. Hi, Karen. So, hello, everyone. Welcome once again. So, today we are diving into a topic that is huge for both certification and real world coding. Yes, I'm talking about the colonoscopy and also the hemorrhoid treatment coding. So by this end of this session, you will have clear and confident understanding of the difference between different type of intestinal scopies, how to apply the CPT guidelines, the modifiers correctly, and also you will have an idea of the hemorrhoid treatment procedures. Okay, so let's begin. Okay, so in your CPT manual, you can find the colonoscopy and hemorrhoid treatment codes under the digestive system section. So colonoscopy codes are organized under the colon and rectum, specifically within the endoscopy subsection. That is between 45300 to 45398, and also hemorrhoid treatment codes are organized under the anus subsection, that is 46200 to 46999. So you can find the hemorrhoid procedures such as hemorrhoidectomy under the excision subcategory. Also you can find some under the repair as well as destruction. Okay, so before we start, all right, give me a second, Curtis. Just give me a second. Okay. So before we start talking about the colonoscopy coding, we need to step back and review the anatomy of the large intestine and colon. So large intestine is the final part of the digestive system, as you all know, and its main job is to absorb water and store the waste before elimination. So it begins where the small intestine ends and continues all the way to the anus. Okay, so the colon has mainly six parts. It begins with the cecum. As you can see, this is the first part of the large intestine where the small intestine empties and appendix is attached here. Then we have ascending colon, which travels upwards and on the right side of your abdomen. Then we have the transverse colon. This crosses the abdomen from right to the left. followed by descending colon over here, which travels downwards on the left side of the abdomen. And then we have sigmoid colon. This is an S-shaped section that connects the descending colon to the rectum. And finally, you have the final section that is rectum. Yes, the final section before the anal canal. So a complete colonoscopy means the scope is advanced through the rectum and sigmoid colon across the transverse colon and all the way to the cecum. Right. So this is basic anatomy of your large intestine and colon. All right. Oops, I think my on clicks are off. Okay. All right. So the first thing first, what exactly is a colonoscopy? A colonoscopy is an endoscopic procedure where the provider insert a long, flexible tube with camera called colonoscope through the rectum and carefully advances it through the entire colon. So the scope moves in exact this order. So it starts with the rectum, it moves to the sigmoid colon, then it reaches the descending colon, followed by transverse colon, ascending colon, and cecum. Now, why do the provider performs a colonoscopy, and what can they actually do during these procedures? So, during the colonoscopy, physician can directly visualize the lining of the colon. So this can be also done for the colorectal cancer screening and also to identify polyps and inflammation or even tumors. So during the procedure, the physician might remove the polyps or take biopsies or control the bleeding if needed. And on this slide, you can see how a colonoscopy is performed. And the patient here is asked to lie down in the left side, also known as left lateral position. And the patient is typically given moderate sedation for comfort. So colonoscope is then gently introduced through the anus and advanced through the colon. And if any abnormalities is found during this procedure, provider may sometimes take the biopsy or remove the polyps or control the bleeding. All right. So this is how a colonoscopy procedure take place. Okay. So next, let's look at the definition of the large intestine endoscopic procedure. So first up is colonoscopy. So colonoscopy is the examination of the entire colon. As I said previously, it starts from the rectum all the way to the cecum. And sometimes the provider may go a little further into the terminal ileum or the small intestine proximal to an anastomosis. So the key word here is that entire colon. Yes, if the scope reaches till the cecum, we are coding for a colonoscopy procedure. Next is the sigmoidoscopy. Okay, so here in sigmoidoscopy, the physician will examine the entire rectum, the sigmoid colon, and it may also include the portion of the descending colon. After this, we are looking at the proctosigmoidoscopy. So, proctosigmoidoscopy is more limited compared to a sigmoidoscopy, and it examines the rectum and sometimes may include the portion of the sigmoid colon. And the last one is colonoscopy through stoma. So here, colonoscopy through stoma is performed through a colostomy opening. So you can see in the image there is a colon. Okay, let me take the point. You can see a stoma over here. This is known as colostomy opening, and here in such cases, the scope is inserted through this opening and not through anus, and it examines the entire colon, starting from the stoma and all the way till the cecum. And this may also include the terminal ileum or small intestine near the anastomosis. All right. Okay. All right, coders. Now let's look at this from the coding perspective. Okay. So, oops. Okay. So, according to the CPT, we have separate and distinct code sets for these three procedures. That is your proctosigmoidoscopy, sigmoidoscopy, and colonoscopy. So we have different CPT codes. And as you can see in the slides, each procedure has its own CPT code range based on how far the scope advances and what is performed during the procedure. So, very, very important rule to remember, code based on the anatomy viewed and not the scope used. All right, so always keep in mind code as per the anatomy viewed, not the scope used. Okay, so these are the codes for the proctosigmoidoscopy, and the code ranges from 45300 to 45327. And next we have sigmoidoscopy code series that starts from 45330 to 45350. See? Okay. And finally we have code series for colonoscopy that starts from 45378 and it lasts till 45398. Okay. So these are the codes for colonoscopy. All right. Now, let's talk about colonoscopy coding guidelines. And this is where the intent really matters. And it is also where most of the coding error occurs. So stay with me, coders. First, we need to clearly understand the difference between a screening diagnostic colonoscopy and a therapeutic colonoscopy. So, okay, just give me a second. All right. Hmm, I think there is some issue with my slide here. Just give me a moment. Interesting. All right. It's now corrected. All right, Coda. So what is a screening colonoscopy? A screening colonoscopy is performed on an asymptomatic patient, most commonly for colorectal screening, right? So that's clear. And the diagnostic colonoscopy is performed when the patient has symptoms such as gastrointestinal bleeding, anemia, abdominal pain, etc. So that's the difference between a screening colonoscopy and a diagnostic colonoscopy. And we also have a therapeutic colonoscopy. So a therapeutic colonoscopy is performed when there is some procedures like a colonoscopy become therapeutic when provider performs an intervention such as removing the polyp, taking the biopsy, controlling the bleeding. So these are the interventions. So in those circumstances, the endoscopy procedure become a therapeutic colonoscopy. All right. So I hope the difference is clear. And now let's move on to the guideline. So as per the CPT coding guidelines, when the patient is scheduled and prepared for a complete screening or diagnostic colonoscopy, and the physician intends to reach the cecum but cannot reach the cecum due to unforeseen circumstances. In such scenarios, you use 45378, which is the diagnostic colonoscopy, and 45388, which is a colonoscopy through stoma CPT code with a modifier 53. All right. And in case of a therapeutic colonoscopy, if the provider performs the treatment but the scope does not reach the cecum, then you will report appropriate therapeutic colonoscopy CPT code by appending a modifier 52 with it. All right, that is an important guideline. Is that clear, coders? Let me know in the chat. Are you following? Great. Okay, so let's move on to the next guideline. So report a flexible sigmoidoscopy codes that ranges from 45330 to 45347 for endoscopic examination during which endoscope is not advanced beyond the splenic flexure. Okay, so in case of endoscopy procedure where the endoscope does not goes beyond your splenic flexure, it is when you assign the codes for sigmoid or colonoscopy. That is 45330 to 45347. Also, you will assign the flexible sigmoidoscopy code for the endoscopic examination of a patient who has undergone resection of the colon proximal to the sigmoid. Example, a subtotal colectomy and has an iliosigmoid or iliorectal anastomosis. So, when a patient had a subtotal colectomy and is now with an iliosigmoid or iliorectal anastomosis. In such cases, the endoscopic examination will be coded to the code series for sigmoidoscopy. All right, and report pouch endoscopy codes 45385 and 45386 for endoscopic examination of patient who has undergone resection of the colon with ilioanal anastomosis. And finally, I think this is the last guideline. Report colonoscopy code 45378 to 45398 for endoscopic examination of patient who has undergone segmental resection of the colon, that is hemicolectomy, sigmoid colectomy, or lower anterior resection. All right. So, also important guidelines to remember is that when the bleeding occurs as a result of an endoscopic procedure, the control of the bleeding is not separately reported during the same operative session. So, if an endoscopic procedure is done and there is a bleeding, and if the physician manages that bleeding within the same operative session, that management or that control of the bleeding is not separately reported. All right, so these are the few important guidelines from the endoscopy procedures. Okay, now, do you know that you have a colonoscopy decision tree in your CPT manual? Do you know that? Have you seen this colonoscopy decision tree? Because this is going to be super helpful. This is gold. Okay, so everything starts with one question. Was the colonoscopy a diagnostic one or a therapeutic one? So, if the answer is diagnostic, then comes the next question. How far did the scope go? In case it did not reach the splenic flexure, then you have to code for the flexible sigmoidoscopy code for 5330. All right. And if it went beyond the splenic flexure but did not reach the cecum, in such cases, you code for the colonoscopy code 45378 and assign a 53 modifier. And this was one of the guidelines which I was referring to in the previous slide. All right, yes. Thank you for letting me know. And in next scenario, when the scope reaches the cecum, in those scenario, you use the normal colonoscopy code. That is 45378. That is for a diagnostic colonoscopy. All right, and no modifier is assigned. See how easily we can identify the codes using this colonoscopy decision tree. Okay, now in case if the procedure is therapeutic, again the questions are the same. How far did the scope go? If it did not reach the splenic flexure, then you assign the flexible sigmoidoscopy code 45331 to 45347. And in case it went beyond the splenic flexure but did not reach the cecum, then you code appropriate therapeutic colonoscopy code 45379 through 45398 and assign a modifier 52 with it. Also, if the scope reaches the cecum, then you will use appropriate therapeutic colonoscopy code and no modifier is assigned. So this is how you can use this colonoscopy decision tree to arrive at the correct answer. Okay, so let's move on. All right. Now that we have covered the colonoscopy coding guideline, let's move on from colonoscopy and shift our focus to the hemorrhoid treatment procedures. So hemorrhoids are actually normal structure and they are vascular cushions which is made of veins, connective tissue and smooth muscles and they are actually located in the anal canal. And hemorrhoids only become a problem when they enlarge, prolapse and bleed or become thrombosed. So, from clinical and coding perspective, hemorrhoids are actually divided into two main types based on their location in relation to the dentate line. So, they are classified as internal hemorrhoids and external hemorrhoids. Okay, so internal hemorrhoids they are located above the dentate line. So you can see how or the position of the internal hemorrhoids in this particular image and we also have the external hemorrhoids. So external hemorrhoids are actually located below the dentate line and they can also become thrombosed, right? So internal hemorrhoids are again in turn classified into four grades and this grading is very important. So grading of the internal hemorrhoids are like grade 1 to grade 4 and grade 1 is when bleeding happens but it does not prolapse and in grade 2 prolapse occurs but reduces spontaneously and in grade 3 prolapse and occurs and it requires manual reduction and grade 4 is when it is permanently prolapsed and it is non reductible. All right, so you can see in the image the different grades of the prolapse, grades of the internal hemorrhoids. So once it reaches near the stage 3 or stage 4, that's when we go for the surgical management of the hemorrhoids. Okay, so now that we know about the hemorrhoids, let's talk about hemorrhoid treatment. And there is an important term that you will see repeatedly in the operative reports for the hemorrhoid procedures. That is hemorrhoid columns. So hemorrhoid columns, also known as hemorrhoidal cushions, or these are normal vascular structures that is located in your anal canal, and they are made up of blood vessels and connective tissues, and they play an important role in anal continence by helping to seal the anal canal. So this is why the providers often describe the hemorrhoids using clock face orientation. Okay, so there are typically three internal hemorrhoid colon located above the dentate line, and their classic positions are left lateral, right posterior, and right anterior. So from coding perspective, clock face documentation is extremely helpful because it allows us to identify how many hemorrhoid columns are involved and whether the treatment was applied to the single column or multiple sites. Okay, so you will see this term, the hemorrhoid columns, often in hemorrhoid surgery notes. All right. All right, Chorus. Now let's talk about hemorrhoid treatment, starting with one of the most common non-excisional option that is rubber band ligation. So this is a non-excisional treatment, which means no cutting, no removal of the tissue, and the hemorrhoid is treated by cutting off its blood supply. So a small rubber band is placed at the base of the internal hemorrhoid and this cut off the blood flow to the hemorrhoid. So without blood supply, the hemorrhoid shrinks, dies, and eventually falls off on its own. And from CPT perspective, you use the code 46221 for hemorrhoidectomy internal by rubber band ligations. Okay, so 46221 is the code that is used for a rubber band ligation procedure. All right. Next, we have internal hemorrhoidectomy by ligation other than rubber band. So, still, this is also a non-excisional treatment, but it is not a rubber band ligation. Instead of rubber band, the physician uses other techniques such as suture ligation or clipping methods or other ligating devices. Okay, and then we also have destruction of internal hemorrhoids using thermal energy. This means that this does not involve cutting, removing tissues, and it does not also involve the tying of the hemorrhoids. Instead, the hemorrhoids is destroyed using heat. And in this procedure, provider applies the thermal energy directly into the internal hemorrhoids, and it causes coagulation of the tissue, scarring, shrinkage of the hemorrhoid over the time. So, most common methods for thermal destruction include infrared coagulation, cautery, and radio frequency. So, CPT code 46930 is used for internal hemorrhoids, destruction of the internal hemorrhoids by thermal energy. And the CPT code 46945 and 46946 is used for hemorrhoidectomy internal by ligation other than rubber band. Okay, so 46945 is used for single hemorrhoid and 46946 is used for two or more hemorrhoid columns or groups. All right, next let's move on to the next one. Next, we are talking about more advanced and non-excisional hemorrhoid treatment that is called as transanal hemorrhoidal dearterialization or THD. So here the provider uses Doppler ultrasound and this helps to locate the arteries supplying blood to the hemorrhoids. So once identified, those arteries are tied off and this procedure is called as dearterialization procedure. So by cutting off the blood supply, hemorrhoids once again shrink and stop bleeding and it improves over the time. So during the THD, provider may also perform sometimes mucopexy. So mucopexy means lifting the prolapsed mucosal tissue and suturing it back to its normal position. So mucopexy procedure is included in THD procedures and they are not separately coded. All right. Now let's move on to the excisional hemorrhoid treatment procedure. So this is where actual surgical removal of hemorrhoidal tissue is performed. So excisional hemorrhoidectomy means the hemorrhoid tissue is cut off and it is removed. So this is so here no ligation or no destruction happens. It's actually a surgical excision procedure. So excisional hemorrhoidectomy can involve the internal hemorrhoids, external hemorrhoids, or combination of both internal and external hemorrhoids. So CPT codes are based on the location, whether it's internal, external, or both, number of the columns or groups involved, as well as whether additional procedures are performed. So if any, so 46255 is used for internal and external hemorrhoidectomy, single column or group, and if additional procedures are done, such as fissurectomy, you use 46257. If hysterectomy is performed, you use 46258, and 46260 is used for internal and external hemorrhoidectomy, two or more columns or groups. Again, if additional procedures are performed, you use 46261, which is for fissurectomy with fissurectomy, and 46262, which is for with fistulectomy. And 46250 is used for external hemorrhoidectomy, two or more columns or group. Okay, and important guidelines to remember here is that if only one external hemorrhoid or column is excised, then you use the unlisted procedure code that is 46999. Okay, and finally we have few more codes that is 4649947 that is for hemorrhoidopexy procedure by stapling. Then we have code for injection of or injecting of a sclerosing solution that is 46500. Then we have 46220 for excision of single external papilla or anus tag. Then we have 46230 that is for excision of multiple external papilla or tags anus, and 46083 for incision of thrombus hemorrhoid external, and lastly 46999 that is for unlisted procedure anus. And that's all about hemorrhoid CPT code, hemorrhoid procedures and CPT codes. Now it's time for us to move on and do some coding exercise. Okay, Kola. So let's begin with exercise number one. And I'll read out the scenario. You got 2.5 minutes to answer. Your question is: of the following answers, which best describe the correct CPT coding for this procedure? Option A 45378 with a 53 modifier. Option B 45380. Option C 45380 with a 52 modifier. Option D 45330. A patient undergoes colonoscopy due to positive FIT test. After proper bowel preparation and sedation, the colonoscope is inserted through the rectum and advanced beyond the splenic flexure into the descending colon. At this level, physician identifies small polyp and removes it using cold biopsy forceps. When attempting to continue advancing the scope towards the transverse colon and cecum, the physician encounters dense adhesions and unable to safely progress further. Due to the risk of perforation, the procedure is stopped. No further intervention is performed. The patient is stable and discharged. Of the following answers, which best describe the procedure? All right, coders, you've got 2.5 minutes to answer, and your time begins now. Place your best answers in the chat. All right, so most of you have went with option C here. Okay, so let's go ahead and let's see if it is the correct answer or not. Okay, so here we have a patient who underwent a colonoscopy procedure, and yes, patient came with a positive FIT test, and then a colonoscopy was performed, and the scope advanced beyond the splenic flexure into the descending colon, right? But the scope was patient, the physician was unable to advance the scope beyond the transverse colon and cecum. So that's what happened in our scenario. So let's have a look at the code options which we have. So we have code CPT code 45330, which is coding for a sigmoidoscopy flexible diagnostic, including collection of the specimen by brushing or washing when performed. Now, this is a wrong code. We are not looking at a sigmoidoscopy here. There was a colonoscopy performed, and the physician was able to advance beyond the splenic fracture, right? So this is definitely not going to be a sigmoidoscopy code. So I can eliminate option D 45330 straight away. And also let's have a look at option 45378. 45378 is coding for a colonoscopy flexible diagnostic procedure, right? So we know that this is not a diagnostic colonoscopy because the physician did perform a biopsy, right? So this is not going to be a diagnostic colonoscopy. So I can eliminate option A as well. So here we go. Option A is also wrong. Now we are left with option B and option C. So between option B and C, both are coding for 45380. That is for colonoscopy diagnostic, colonoscopy flexible with biopsy, single or multiple. Now let's use the colonoscopy decision tree to solve this one. All right. So was it first question? Was it a diagnostic procedure or a therapeutic procedure? So the answer is it is a therapeutic procedure. And till which extent did the scope go? It went beyond the splenic flexure, but it didn't reach the cecum here. So then, in such cases, we have to use the colonoscopy codes, the therapeutic colonoscopy code with a modifier 52. So here a colonoscopy with biopsy was performed. So along with 45380, we have to assign modifier 52. And that eliminates option B, and the correct answer is going to be option C, 45380 with a 52 modifier. As most of you have said, option C is going to be the correct answer. All right. How are you all doing, coders? Did the explanation help? Please let me know. All right. So let's move on to the next question. Exercise number two. Okay. Of the following answers, which best describe the correct CPT coding for this procedure? Option A, 46221. Option B, 46945. Option C, 46947. Option D, 46255. A 48-year-old patient presents with painless rectal bleeding and intermittent prolapse. An anoscope examination reveals symptomatic grade 2 internal hemorrhoid located above the dentate line at 11 o'clock position. During the same session, physician performs a rubber band ligation and places bands at the base of the internal hemorrhoid tissue to cut off the blood supply. The procedure is complete without complication. Of the following answers, which best describe the correct CPT procedure for this, which best describe the correct CPT coding for this procedure? Okay, coders, you got 2.5 minutes. I think this is a straightforward one, and you must be fine with this. Okay, so your time begins now. All right. So for this one, we do have mixed responses, mixed answers in the chat. So let me go ahead. Let me walk you through this one. So here, what we have is a patient with a grade 2 internal hemorrhoid and a rubber band ligation was performed. All right. So let's look into the each CPT code options which we have. Option C is coding for 46947. That is for hemorrhoidopexy procedure by scaling. Did we have an hemorrhoidopexy done here? No, we didn't have an hemorrhoidopexy. It was a hemorrhoidectomy procedure by rubber band ligation. This is not a hemorrhoidopexy. So that's why I would eliminate option C 46947. That is wrong. It's coding for a wrong procedure. Let's look into the next CPT code. Option D, that is 46255. It is coding for an hemorrhoidectomy, internal and external single colon or group. All right. Now, why would I say option D is incorrect? I would say option D is incorrect because option D is coding for a surgical excision procedure, right? I said in the beginning that there are different type of hemorrhoid treatment procedures. You can have an hemorrhoidopexy. There is hemorrhoidectomy procedure that can be done by surgical excision. That can be also done by a ligation technique. Then you have a destruction of hemorrhoids, which can be performed using thermal energy. So there are a lot of options for treating an hemorrhoid. So this is not a surgical excision that is performed. This is a rubber band ligation. And now between option A and option B, let's have a look. Option B is coding for 46945. That is for hemorrhoidectomy, internal. Okay, hemorrhoidectomy, internal by ligation other than rubber band, single hemorrhoid colon or groups. So this and 46221 is for hemorrhoidectomy internal by rubber band ligation. So the main difference between these two CPT code is that option 46221 is coding for a rubber band ligation, while 464945 is coding for a procedure, a ligation procedure other than rubber band method. Okay, so we had a rubber band ligation. That makes option B incorrect and option A the correct one. All right, okay. So did the explanation help? Let me know. Let me know in the chat. Okay, so let's move on to the next exercise. The correct CPT coding for this procedure. Option A 45378 with a 52 modifier. Option B 45330. Option C 45378 with a 53 modifier. Option D 45330 with a 52 modifier. A 52-year-old patient with presence with the rectal bleeding and lower abdominal discomfort. A flexible endoscopic examination is performed. Endoscope is inserted through the rectum and advanced through the sigmoid colon into the descending colon. Examination was intentionally limited and the scope is not advanced beyond the splenic flexure. The mucosa of the rectum, sigmoid colon, and descending colon is carefully evaluated. No advancement into the transverse colon is attempted. Of the following answers, which best describe the procedure? All right, Curtis, you got 2.5 minutes. All right, great answers in the chat. You all got this one correct. Spot on. So great answers, Codus. So what has happened here? Okay, so we have a patient with a rectal bleeding and a flexible endoscopic examination was performed. The endoscope was inserted through the rectum and advanced through the sigmoid colon, right, and into the descending colon. So the examination was limited in this scenario, and the scope was not advanced beyond the splenic flexure. So that was the key word here. It was not advanced beyond the splenic flexure. So we have two CPT codes, 45330 and 45378. 45378 is for colonoscopy flexible diagnostic, and 45330 is for sigmoidoscopy flexible diagnostic procedure. So yes, we have to code as per the anatomy viewed and not as per the scope. And from this scenario, it's clear that there was no exam. The examination of the entire colon was not performed and was limited to the sigmoid colon because the scope couldn't go beyond the splenic flexure, right? Yes, and the CPT guidelines says that report flexible sigmoidoscopy code 45330 to 45347 for endoscopic examination during which the endoscope is not advanced beyond the splenic flexure. So it didn't went beyond the splenic flexure. That makes this a sigmoidoscopy procedure. So your option A is incorrect for 5378. That's for a colonoscopy. Option C is incorrect for 5378 with a 53 modifier. That is also coding for colonoscopy. And you have to code for a sigmoidoscopy. This was not a reduced procedure. So you have to code for a sigmoidoscopy procedure. That would be for 5330. And option B is the correct answer. And I see that everyone went with the option B. So great answers. Excellent job. And let us move quickly to the final segment of this session, that is the hand poll. All right, coders. So here is your rapid hand poll session. Question number one: a diagnostic endoscopic examination evaluates colon from the rectum all the way to the cecum. No biopsy or treatments are performed. Which procedure is reported? Option A, sigmoidoscopy. Option B, colonoscopy. Option C, proctosigmoidoscopy. Option D, endoscopy. Quickly, Chorus, let me know your answers in the chat. What say you? Okay, I can see one answer is already in the chat. There you go. Okay, all right. Yes, you all are going with option B, and indeed, option B is the correct answer. It is to be this procedure is a colonoscopy, right? It went all the way from rectum to the cecum. So yes, that would be a colonoscopy procedure. Next question. A patient is scheduled and prepared for screening colonoscopy. The physician cannot advance the scope to the cecum due to poor bowel prep. No intervention is performed. How should this be coded? Option A, flexible sigmoidoscopy. Option B, 45378. That is a diagnostic colonoscopy code. All right. So option C is 45378 with modifier 53, and option D 45378 with modifier 52. What say you, coders? Quickly, coders. So this is a rapid fire scenario. So quickly, place your answers in the chat. Okay, I have one answer. Yes, I can see. So it was a delay from my end. So you all have praised the answers. Yes, the correct answer is going to be option C. Indeed, yes. It is 45378 with a 53 modifier. Great answers. Next question. Bleeding occurs as a result of biopsy and during a colonoscopy, and the physician controls the bleeding endoscopically. How is this coded? Option A, colonoscopy plus control of the bleeding. Option B, colonoscopy only. Option C, control of the bleeding only. Option D, colonoscopy with a modifier 22. What say you, coders? Okay, I have first answer already in the chat. hmm How about others? What say you, Coders? All right, all right. Yes. I think some of you are still thinking. Okay, the answers are coming now. Great. And the correct answer is going to be option B, colonoscopy procedure only. Because the bleeding that results as a result of a colonoscopy procedure, and if the physician control that bleeding in the same session, you cannot code them separately. And they are included in the procedure itself. All right, so that's one of the guidelines which we reviewed today. So you can code only for the colonoscopy procedure. Excellent job, coders. Wonderful job. And I think with that, we come to a conclusion of today's session anchors. So I will just place the survey link in the chat. Please don't forget to fill out the survey link. And if you have any questions, also let us know. So if you enjoyed the video, smash that like button, subscribe, and share it with someone who needs to see this. Okay, so I have already placed the survey link in the chat, coders. So see you all next week with another topic. Till then, stay safe, keep coding, and see you all next week. Thank you. All right.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around.